As per the latest ACOG guidelines, what is the current recommendation for cell-free DNA testing? Now, this is a very theoretical question, and you either know it or you don't know it. Only for women above 35 years, not really. Only in high risk women. Now, basically, when I started studying OBGY in 2017, 2018, at that point of time, it was that you would do all these dual markers and all this aneuploidy screening only for high risk populations. High risk populations include females who are more than 35 years of age. But as of now, and as of 2025, and rightly so, it is recommended that every single female and not just a high risk patient should be offered at least some form of aneuploidy screening. Now you would ask me cell-free DNA or I mean NIPT or dual marker. It's a great question. A big difference is in the fact you will be having a lesser cost that is required, maybe 3,000 or 4,000 for dual marker, whereas your NIPT is going to cost you somewhere between 8 to 12,000 depending on the lab that you're doing at and in the city you're doing it. So NIPT is obviously much more expensive. But you would ask me then why is it expensive and is it worth if I have the money to do it? Why not just do NIPT for everyone? Now, there are a few things that a lot of labs claim, and there are a few things that are not proven by evidence that you should know about NIPT and dual marker. Now, I've made several sessions on this. I'll just quickly brush up those points. Those few points include when I do a dual marker, of course, you know what's a dual marker, and I'm testing for NT-NB inside it, that is nuclear translucency and nasal bone. This has an accuracy of around 85%. This 85% is going to be 80 to 85 बोल दूंगा मैं. A dual marker is, sorry, not this. Dual marker is, of course, my PAP A and beta HCG. Okay. So this PAP A and beta HCG together has a sensitivity of around 80 to 85% to diagnose Yeah. So this has an accuracy of diagnosing 80 to 85% of the cases with aneuploidies only when it is combined with NT-NB as well. Whereas if you do this individually, then it is only going to have a sensitivity of around 70 to 75%, and NT-NB is going to have a sensitivity of 75 to 80%. So effectively, if I take a common figure that is 75%, I am missing out on 25% of the cases of aneuploidies. Hence, when I combine both of them, I get a sensitivity of 80 to 85%, which is good enough. If I consider 80, 85, I'm just missing out on 15 to 20% of the cases. That is good enough, but as of in 2025, still not good enough. So what I do is I add two more things to it, and that is tricuspid regurgitation and reversal in ductus venosus. So if there is no reversal and if there is no tricuspid regurgitation, then my sensitivity goes up to 95 to 96%. Basically for trisomy 21, 18 and 13, all of them have this sensitivity. Good. But again, I cannot be just telling a patient that I'm 95% sure that you won't have any aneuploidy in the fetus. The patient says, what do I do about the remaining 5%? What if I am one of them? That's a valid question. So for that, you now have NIPT, but there's a catch to it. NIPT, they say, has an accuracy of 99.9%, although a lot of evidences say only 99%, but ठीक है, the labs claim 99.9% का accuracy है. But remember that this accuracy is only for trisomy 21. For trisomy 18 and 13, this is still between 91 to 96%, which in fact is better off with dual marker. So NIPT, I can say as of now is only good enough for trisomy 21 because dual marker is still superior for 18 and 13. But 18 and 13 often tend to have gross abnormalities that you can easily diagnose on a scan, which is why I can still diagnose it if I'm just doing an NIPT by doing a proper anomaly scan, whereas trisomy 21 will have a few subtle, very subtle abnormalities or soft markers as we call it, which is why it is something that I definitely should not be missing out on. Hence, a lot of labs, by the way, if you see, they will even say that we give trisomy 13 and 18 का जो data है वो 99% देते हैं, but remember it is not backed by evidence. Evidence मतलब meta analysis, Cochrane reviews उससे backup नहीं किया, उनके personal private studies जो उन्होंने किए उसमें हुआ रहेगा, but we are still to get there as per uniform basis of evidence. We will get there. The more we do this test, the more the price is going to come down. It is going to be affordable for everybody, just like dual marker is now. and this 18 or 13 का भी accuracy बढ़ेगा, but we just need to do a lot more of tests so that they get a lot more data for their database to develop this test, which is why NIPT is exclusively sorry good for trisomy 21, whereas for 13 and 18 it is just 91 to 96%. Now the question here read that as per the guidelines, what is the current recommendation of cell-free DNA testing? So the current recommendation for cell-free DNA testing is, of course, everybody should be recommended it, and it is a test that everyone should do it because there is no harm in doing it. There are no maternal or fetal risks that are associated, and it is actually a very good screening test, which is, even if nothing, is giving you more than 90% accuracy rate for all the trisomies and 99% for trisomy 21. But because cost may be a constraint and also 13 and 18 का थोड़ा कम है, is why I would still prefer, if I have to give one test, if I have to do one test, it will be dual marker. One more thing with dual marker is that it is not just dual because there are PAPA and beta HCG on it. It is also dual because it also gives me the risk of the fetus developing FGR and preeclampsia, the mother developing preeclampsia in future. So it serves two purposes. It gives me maternal as well as fetal risks in future. And hence, it is a very good test to be done, dual marker, which has to be done between 11 to 14 weeks, or to be more precise, when the crown rump length is between 45 to 84 millimeters. Hence, this has to be recommended to all the patients. Recommend them if they are not able to do it, affording nahi hai, thoda paisa kam hai, to theek hai, mat karo, but at least do a dual marker, which is going to cost you much lesser. And you would say dual marker plus NT-NB scan ka bhi kharcha aata hai. Get the NT-NB scan done in a government setup, in a civil hospital where it is free of cost, and do the dual marker outside if the hospital is not doing it. So basically, you still save up on the scan, on the ultrasound, and the overall cost of the entire combined first trimester screening. That is dual marker plus your ultrasound is going to only come around 3,000 or 4,000. So remember this for sure, that you have to do for all patients and not just for high risk patients, because nowadays you are getting so many patients who are like 28 years old, 30 years old, who are getting babies with Downs. And that is why you need to be understanding the fact that just above 35 years of age, the risk increases. But the risk is not zero for women below 35. So do it for every single woman. It is not optional. It is a must do test for you all. Of course, जैसे screening is a good thing to be done. अगर कल आके तुम लोगों को कोई बोलेगा कि मैमो for females करना है, it's a good thing to do. Cervical screening, pap smear करना है, तो it's a good thing to do. But what would you prefer? You would want the best for your own friends, families, and patients, which is why you would definitely do them. Hence, just follow the same dictum. Though screening is an optional thing to do, but you should not keep it optional. You should make it a mandate. You should make sure that all your patients are doing it so that you can just not miss out on any patient with any form of aneuploidy. Okay, the next question. Which component is not a part of the combined first trimester screening? The first point is NT. Yes, of course, it's a part. Serum PAPA. Yes. Serum beta HCG. Yes. Maternal AFP is not a part of, alpha fetoprotein is not a part of your combined first trimester screening, because your alpha fetoprotein along with unconjugated estriol, triol hai, 3 hai, plus HCG, and the last one कौन सा है वो तुम लोग मेरे को बताएगा, so that I know you all are focusing on the topic. I have asked this question for a specific reason. I need to know the exact alphabet, and then I would know that you all are paying attention. Inhibin A, correct. Prathamesh, the answer is correct. It is, remember, inhibin A. A lot of people just say inhibin. No, it is not inhibin. It is inhibin A. B is the one that is present in normal women who are not pregnant. In patients who are pregnant, it is going to be inhibin A. Remember, you can think of it this way, that inhibin A is going to be A for aneuploidy. Correct answer. Excellent answer. In fact, A for aneuploidy is a good way to remember it. The way I used to remember it is A for A, because सबसे पहला alphabet है, so it is one of the first things that we learn, ABCD, which is why one of the first things that comes to me when it's a baby is A. Basically, life का starting A से हो रहा है, तो A मतलब ही aneuploidy के testing के लिए use करोगे तुम लोग. Anyway, that's a good way of remembering. A is for aneuploidy. So inhibin A is very important, and these are all the things that you'll be doing. These are the quadruple markers. Unfortunately, the accuracy of quadruple marker is again only 80 to 85%. In fact, 80% ही लेके चलो. You would ask me, अभी दो की जगह मैं चार टेस्ट कर रहा हूं. Yet, why do I say that the accuracy has gone down? Remember, the specificity of the test has increased, but the sensitivity has gone down because I have left out PAPE now. PAPE was a very strong player of that helped me in the understanding of the fetal aneuploidies, which is gone, and hence the overall sensitivity came down drastically. Hence, the specificity improved, but the sensitivity went down, and this quadruple marker is only and only to be done if you have not done dual marker, or if the patient is not able to afford NIPT as well, then only you do quadruple marker. Do not do your quadruple marker if you have done a dual marker, if you have done an NIPT. It is pointless. It is only for those patients who cannot afford NIPT and have not done dual marker. When do I do it? It is done after 16 weeks, and you have to do it till the biparietal diameter of the fetus reaches 50 mm, that is 5 centimeter, which is approximately up to 20 weeks. So, बाय द वे ड्यूअल मार्कर का मैंने बताया करना है बिटवीन 11 टू 14 वीक्स. क्वाड्रुपल मार्कर का अप्रोक्सीमेटली करना है until the BPD is less than 50 mm. Can someone tell me until how long can I do NIPT? They say 10 weeks, but I preferably do it after 12 weeks. From 12 weeks, could someone tell me until how many weeks of gestation can I do NIPT? Quickly tell me. Just quickly tell me. No limit. Good, interesting answer. Anybody else? Quickly. Okay, so the answer given by Prathamesh is actually correct. There is no limit to it. You can even do NIPT at 40 weeks of gestation, because in your blood, the cell-free DNA is always going to be present. It is just that after a certain point, there is no reason or there is no use of doing NIPT. Hence, you would preferably not do it. देयर इज नो रीजन. फ्यूचर में जाके रीजन मिलेंगे तो तुम लोग कर सकते हो. सो देयर इज नो एंड टू इट. यू कैन डेफिनेटली डू सेल फ्री डीएनए एट एनी gestation. If your patient has come to you for the first time at 26 weeks and you have done no screening, nothing, then you can do that NIPT. And if you get any high risk, then you can do amniocentesis. And now using the MTP amendment of 2021, you can even do MTP. We just performed an MTP for a 33 weeks patient a couple of weeks ago who had Edwards syndrome. So because 33 weeks ka tha, the baby weight was 1.8 kg, there was FGR of course. So what we did was we did feticide. We injected KCL, intracardiac KCL dala humne, and then we started the process of MTP so that the baby doesn't survive after it is born. So that is one of the better uses of the amendment of MTP Act in 2021. And hence remember that NIPT can be used at any gestation, because agar 30 weeks pe bhi positive aata hai and you do amniocentesis and you get a positive aneuploidy, you can still abort the fetus. There is no restriction to abortion or MTP now if there is a lethal anomaly. So the answer is going to be maternal serum AFP.